Good evening, everyone. Welcome you all for the IPNA endorsed Webmaster Series 2021, a Pediatric Glomerular Disease Symposium. Today we are into the webinar 5, and we have the highlight of the session is we have polling sessions as well. And this series is extending till July 14. We have two eminent speakers for the day, Dr. Mattoo and Dr. Rajiv Sinha. The first talk will be by Dr. Rajiv Sinha. Dr. Rajiv Sinha is a certified pediatric nephrologist. He is currently associated with the Institute of Child Health, Kolkata. He is the head of the Department of Institute of Child Health, Kolkata, and he is also a consultant pediatric nephrologist at Apollo Clinicals Hospital, Kolkata. His academic interest is towards renal replacement therapy, including transplantation, hypertension, and his special focus is towards ABPM. And he has received n number of awards, and he is also a recipient of multiple travel grants from ISN, IPNA, BAPN, ESPN, and ASN. He is associated with many other societies, ISPN, IPNA, and he is educational ambassador for International Society of Nephrology, and he has got many honorary memberships, and he has got a lot of articles of his own, and he has got more than 55 publications in national and international peer-reviewed journals, and including 18 original articles. He has contributed multiple chapters and textbook. Now it is Dr. Rajiv Sinha's turn to deliver a talk on congenital nephrotic syndrome. Over to Dr. Rajiv Sinha.
Thank you. So I click on this, right?
Yeah, you just have to move your cursor and tap onto the next to move your slides forward. Yeah.
It's happening, right?
Yeah, okay. It is.
Thank you very much. So, without wasting much time, we will go into the topic of first talk of today. And at the onset, I'd like to thank Dr. Namarvar sir and Dr. Kalaivani and the entire Dr. Mehta's team for giving me the opportunity to be a part of the endeavor to have some academic despite this pandemic. Today we will be talking about congenital nephrotic syndrome as a first talk, and then we will be having the talk which we are all waiting for. I am also to hear Dr. Mattoo speaking about the nephrotic syndrome in general. So for congenital nephrotic, we'll start with the 4-case scenario. Classical case scenario, nothing new in their presentation. So this one, I hope you can see the 12-day-old male baby with generalized anasarca. Mother had a past history of spontaneous abortion at 23 weeks, and there was a history of previous 2 sibling death around 2 to 3 months of age with similar illness. Next case scenario is a 65-day-old male who presented to our institute in shock, septic shock. The child had generalized anasarca, and the family had noticed progressive swelling of the body by day 41. Third is a female who was referred to us around 3 months, and family had started noticing a generalized body swelling around 2 months. So initially went to the quack doctors and then referred to a pediatrician, then referred to us. And the last case is a 9-month female from Bangladesh. Mother is a doctor, is a radiologist, and they noticed a history of swelling of the body and decreased urination at about 2 months. Was managed locally in Bangladesh with diuretics, albumin, and then on and off of diuretics, and then around 9 months they came over here for a second opinion. Sorry. So keeping this 4 scenario in mind, we will move ahead to see that these 4 scenarios have what is in common is the nephrotic range proteinuria. So a very high protein creatinine ratio, a low albumin, giving us a diagnosis of nephrotic syndrome, and as their presentation was within 3 months, so it is congenital nephrotic syndrome. And this is what we are going to discuss today. We will divide this talk in two halves. The first half, we will concentrate on how to evaluate a child with congenital nephrotic syndrome. And in the second half, we will discuss a bit on the treatment, and we will try to bring in some Indian perspective into the management aspect. So, starting the first half, how to evaluate. Now, when you are evaluating a child with CNS, I believe one of the top priorities should be to try to find out what is the etiology. This is for two reasons. If we say, one is that if you are trying to identify a genetic, then you can prognosticate, and the overwhelming percentage of these children with congenital nephrotic syndrome do have underlying genetic cause. But also we have to try to identify congenital infections, which are not that uncommon in our society. And the plus point is that if you identify a congenital infection, then maybe you can offer something concrete to this family, or at least to the child, more importantly to the child. Also, we have to remember the non-genetic, non-infective causes like maternal alloimmune causes, maternal SLE, etc. Whenever you are dealing with a heterogeneous disorder, it is very important that you remember your ABC. And your ABC of medical science still remains. I strongly believe in a proper history and evaluation. I'll not go through this slide in detail. It is taken from the European Society of Pediatric Nephrology guideline. Just to summarize that, if you are, and I will be repeating this again, but we depend a lot on genetics in congenital nephrotic syndrome, but remember that your genetic results may be wrong if you are not giving them the right information, and the right information comes from your history and from your evaluation. So, family history, consanguinity, ethnicity, past history of congenital nephrotic syndrome, early infantile death, perinatal history, fetal edema, oligohydramnios, placental weight, all of this has to be there. For your evaluation, a standard anthropometric is very important for congenital nephrotic syndrome.
Yeah, I don't see his slide.
Yeah, Dr. Kalamani, can you see the slides?
Okay, now
yeah,
I can see
your slides, sir.
Okay.
I'm able to.
Sure. Okay. So I was saying about this anthropometric is important. Physical examination when you are doing for a congenital nephrotic syndrome, number one is obviously the anthropometric and the vitals, because vitals will be also telling you whether your child is in hypovolemia or not. And as we will discuss later, this decides whether you need an albumin or not. Physical examination will also tell you things like any dysmorphic features. Genital examination is important. We all know about the WT1 mutation. Ophthalmologic examination not only for Pearson but also for congenital infections. Physical examination will also give you telltale sign of various congenital infections like hepatosplenomegaly, rash, etc. Simple CBC, obviously you will do it. Renal parameters, you will check it, but along with that, we normally do a thyroid function test, a lipid profile, immunoglobulin levels, and a bone profile. And usually, most of these children do end up having a echo spring. I will spend one slide on congenital infection, and again highlighting which I said before. This is a publication from Velo, and just look at that catchy title. Congenital nephrotic syndrome, a treatable cause. How could they make this audacious statement? Primarily because they were able to identify syphilis, and they treated syphilis and the child became well. Similar to this, we have got case report of toxoplasmosis getting better. We have got case report of nephrotic syndrome from CMV getting better. But then remember, sometimes this can be red herring also. This is a publication from Israel where they not only had a child with congenital nephrotic syndrome with CMV serology positive, they also showed the CMV in the renal biopsy. But still, treatment did not make any effect. And ultimately, this child turned out to be positive to Prednisone mutation. Similarly, in our publication a couple of years back, we had had 4 children with documented PCR positive CMV, all treated with Zanzalintinib, and in none of them it worked, and in one of them nephrin was positive. So the take-home message from this is that even if you are having a congenital infection being positive, don't forget your genetic causes. One slide on which is something which is not that common, or I don't know whether it is not that common because we are missing it. And these are a congenital nephrotic syndrome secondary to anti-neutral endopeptidase antibody. Described around 2002, what was found was that there are some babies who are presenting with congenital nephrotic syndrome, have a biopsy finding of membranous nephropathy, and they have got spontaneous resolution. And it was found subsequently that this was because of anti-neutral endopeptidase antibody coming from the mother through the placenta. And after birth, as the supply of anti-NEP antibody ends, these children do go into spontaneous resolution. Initially, it was thought that it is they only present with the nephrotic syndrome, but then subsequently it was shown that they can also present with severe renal failure, oligohydramnios, and even may require dialysis. So keep this entity in mind, particularly if you are having a history of previous pregnancy, initial child presenting with congenital nephrotic syndrome, and then resolution by itself, or previous pregnancy with abortion, with fetal loss. So this should be kept in mind. I personally am not sure whether anti-NEP antibody is done in India. I couldn't find any place where it is done. But one way out is that you can do a genetic test in the mother and diagnose this condition. So that brings back to the genetic workup, and across the globe, studies have shown, particularly if you are using whole next-gen sequencing, more than 80% of cases of congenital nephrotic syndrome have a genetic underlying etiology. But which is the common, these big 5 are the common genetic etiology: the NPHS1, that nephrin, Prednisone, WT1, PLC1, and LAM2. This 5 contributes to more than 80% cases of all underlying genetic etiology for congenital nephrotic syndrome. Recently, the European Society has come up with this recommendation of on genetic workup. Again, I'll not go into the details of it, and it is available online, but I'll just highlight some of the salient features which I thought is important. Don't worry about this slide. You don't have to read the whole of it. But the publication does give you a detailed phenotype. So if you're suspecting, if you're working up a genotype, you need a phenotype, because that's what you are trying to do a genotype-phenotype correlation always in your life. And this publication has a detailed list of various phenotypes that is associated with congenital nephrotic syndrome and can be a good reponder. And if you look through the things which I have sort of made it in bold, and again emphasizing the importance of a detailed examination. So you can see the congenital nephrotic syndrome children, you need to examine all the system, because in various forms all the systems may be involved. The guideline clearly said that the first choice diagnostic test in every CNS patient is genetic, and either you can go for a 1-step or 2-step. What does that mean? Ideally, you can go for a whole exome sequencing. Advantage is that that it will not only give you the genes which are known, may even give you the question which you are not, may even give you answer to some questions that you don't even know. But if it is costly, then you can initially focus on, say, those 5 major genes that we discussed, or even if you're very confident about a phenotype, you can just focus on that phenotype. And then you can, maybe you don't even have to do a NGS, you can go for a Sangus, which is slightly cheaper. And if and if that comes negative, then you go for a whole exome. My personal practice is that we are now, after a lot of negotiation, we are getting clinical exam very cheap in our institute, and we normally go for a clinical exam for congenital nephrotic syndrome. Do a karyotype for all congenital nephrotic syndrome with ambiguous genitalia, and for phenotypic female with WT1 mutation. To be sure, you are not missing the things like Frazier syndrome, and you are offer, because if you know that, I'm sure you remember that they can have this gonadoblastoma, and this has got important implications. Sample EDTA blood or umbilical cord sample can be also used, and they really emphasized on genetic counseling in families, which is very important. Most of the congenital nephrotic syndrome are autosomal recessive, so there is a 25% risk of recurrence in subsequent pregnancy, with the major exception of WT1, which is usually autosomal dominant, although in a significant percentage it can be de novo also. And being autosomal recessive, parents are usually carrier of a heterozygous variants and can be kidney donor, but they need to be worked up before accepting them for kidney donor. Biopsy doesn't play an important role in congenital nephrotic syndrome. Number of studies have shown that there is not a strong correlation between the histopathology and the genetic, apart from a bit with diffuse mesangial sclerosis. But even then also you may not have a strong correlation. So what the guideline advises is that biopsy should be indicated if all the other screening, that is genetic screening, infective screening, as well as the non-infective etiology, all that we have ruled out, we have done it, we haven't found an answer, then we can go for a biopsy. So summarizing our first part of talk, and again taken from the ESPN working group recommendation, we recommend that all patients with congenital nephrotic syndrome are managed by a multidisciplinary team. And the initial test is genetic screening, but this, as we just discussed, is held by a proper, thorough workup of history and medical examination, clinical examination, and not much role of biopsy, and a strong emphasis on genetic counseling. Before going on to the second part, let us see what happened on evaluation of our 4-case scenario. First one, if you remember, is the one at presenting with Anasaka at 12 day, went on to have received albumin infusion and furosemide. This one came as a CMV was positive, the IgM and PCR both. Gave Jansaclavir, but there was no response. And ACE inhibitor was added, but the child remained dependent on albumin and furosemide. And by this time, the genetic test came back, and the child was homozygous mutation for nephrin. Next one, this is the child who presented in a septic shock. Child vital stabilized. In fact, we were able to extubate the child also, but the kidney was not improving. Child was oliguric. We advised for dialysis, family refused, and they took the child home against the medical advice. Subsequently, the genetic came back positive for coenzyme Q2. A bit unfortunate, because as you might be knowing that maybe with coenzyme Q10 supplementation, this child might have improved. Who knows? Third one, the child who presented at around 3 months was kept on furosemide, albumin, and ACE inhibitor, and came back. The genetic workup came back as compound heterozygous for nephrin mutation. And the last one from Bangladesh again became dependent on albumin and fusamate even after ACE inhibitor, and the genetic mutation was positive for WT1 on exon 8. So now we have covered the first part of the talk. For the second part, we now will concentrate on how to treat a child with CNS. Let us go back in time to 1976. This is a paper published in Archives where they analyzed 75 children with congenital nephrotic syndrome of Finnish type from Finland. Very simple study, very simple outcome, that virtually all of them died. So at 6 months, half of them had died, and none of them lived beyond 2 years, 3 months, and the major cause of death was infection. Same journal, Archives, a couple of decades later, this is a study now published from Ireland. And they showed that in this couple of decades, there was a drastic change. If you remember 100% mortality previously, now the mortality had dropped to 30%, and they claimed that in the last 5 years, they have not had any mortality. And what did they do different? This was the introduction of daily intravenous albumin, bilateral nephrectomy, and subsequent renal transplantation. So an aggressive method, and this made a drastic change, shifting from 100% mortality to where you can really dream that most of them will survive. But this entailed early initiation of renal replacement therapy with its challenges. This a paper from one of my mentor from Evelina, Sue Rigdon and Chris Reed, and but they sort of thought that what instead of bilateral nephrectomy, what if we do unilateral nephrectomy? This was a thought process that was being followed in other part of the world also, and they showed that yes, with unilateral nephrectomy, you can sort of push the initiation of RRT till the 3rd year of life, and without causing much difficulty or without causing much negative aspect on the outcome. So when I was working in UK, say in the 2000, this was the two standard method that we were taught. That either you can be very aggressive and you can go for a early bilateral nephrectomy or initiation of dialysis and subsequently transplantation around 9 to 10 kilo of weight, or you can go for a unilateral nephrectomy with ACE inhibitor and then push it. And both of these methods had a strong emphasis on nutrition. But in the early last decade onward, number of information started pouring in. There was this report from William Wong group from Auckland, New Zealand, where they identify a group of Maori with nephrin mutation, but then they were doing remarkably well even without any renal replacement therapy. There were publications coming up. I have just quoted one, but there were other publications also where congenital nephrotic syndrome seemed to be responding to ACE inhibitors. There were publications coming up with nephrotic syndrome in infancy, having a spontaneous resolution and not just because of anti-neph antibody. And now discuss two publications. Both of them happened, was published in NDT, both in the same year, 2018. First one was from France, where they looked at 55 children with congenital nephrotic syndrome. And I'll just read the conclusion that a survival free from ESRD was possible in 2/3 of the patient at 1 year and in 50% of them at 2 years. And a significant reduction or even a discontinuation of albumin infusion allowing ambulatory care was possible in a subset of patients. So this sort of highlights that maybe all sites does not, maybe one site that does not fit all. Same year, there was another publication from the European group, so not including France. This was the whole of Europe, and what they showed was that in their cohort, antiproteinuric treatment like ACE inhibitor made a difference. Unilateral nephrectomy made a difference, and there was a significant improvement in albumin as well as reduction in albumin infusion. And then they compared two groups, both having nephrin mutation positive, One group had undergone bilateral nephrectomy, the original aggressive method, and the other group had been managed in a more conservative method, and they found out that no, there is not much difference. So what these two studies showed is what we always know, but I believe we always forget. I am repeating it. We always know, but we always forget that one size does not fit all in nephrotic syndrome. And I believe I'm not a COVID expert at all, but I think the same is being done with the COVID also. Like we are looking for a protocol, a fixed protocol, but that doesn't happen in medical science. And I will read this conclusion that an individualized stepwise approach with prolonged conservative management may be a reasonable alternative to early bilateral nephrectomy and dialysis in children with CNS and nephrin mutation. So because of all these studies coming up, the European group came up with a recommendation. Again, I'll not go through the details. It is available on the web. I'll just highlight some of the salient points. Overall management. The most important thing we are again repeating is the individualized management. They should be managed in a specialized unit. One should start preserving the central and peripheral veins for future venous access, avoid salt overload, optimize fluid, protein and calorie use, anti-proteinuric agent, and look out for thrombosis and sepsis. A bit more detail, what about albumin infusion? The decision to give albumin infusion depends upon the intravascular volume, hyponatremia, edema, nutrition. All this. It is not that all children with the congenital nephrotic syndrome should have albumin infusion. It is not that all children needing albumin infusion should have a central venous line. But yes, if you are seeing that this child is dependent on repeated albumin infusion and fusionate, then a CVL should be inserted, balancing the risk of thrombosis and sepsis. Diuretics, yes, again, you should not be using diuretic, obviously, if the child is hypovolemic. And the group, they advocated the use of amiloride in place of aldactone as a diuretic choice. Antiproteinuric, we have already shown evidence that it works. It does reduce proteinuria as well as does reduce the need for albumin infusion. The group advocated either RAS inhibitor or ARB and then slowly build it up. And a maximum dose is 2 milligram per kg of ACE inhibitor. We often feel a bit shaky going that high up. Now, if ACE and ARB is failing, then you can add indomethacin. But remember that if indomethacin is not working for 2 to 3 months, then stop it. And also remember that if you are using this combination, then if a child presents in a hypovolemia, diarrhea, etc., you should stop the medications. Nephrectomy, we have already discussed it in quite details, and again highlighting the importance of an individualized stepwise approach to decide whether the child really needs a bilateral nephrectomy, first of all, whether the child needs nephrectomy or not. Many of them don't. Then some might just respond to a unilateral nephrectomy rather than bilateral nephrectomy. One of the exceptions is WT1 mutation. WT1 mutation, if the child has gone into end-stage renal failure, it's always good to remove the kidney. Why keep something which is not working and can cause problem in the future? Trial of immunosuppressant only to be used for negative genetic and infective screen, and a biopsy ruling out diffuse mesangial sclerosis and after proper counseling of parents. So immunosuppression practically I can say doesn't have any role. We have already discussed about the antibiotics and antivirals. And anti-NEP antibody, again, rare, but and usually responds to conservative therapy. But if it's a severe renal failure, you might want to remove those antibodies. Rest of the management, thrombosis prophylaxis at high risk is indicated. High risk means if there is a CVL or the central venous line or a high platelet count dehydration. Antibiotic prophylaxis is not recommended, but yes, if your immunoglobulin is low and your child is having recurrent infection, then you can give IVIG. Standard prophylaxis and treatment for varicella zoster exposure. Nutrition is very, and you can add another 10, 12, 15 very important. And that's why you need a proper nutrition team. These children require a high calorie dense, protein dense feed, and most of them do end up having thyroid supplementation, vitamin D supplementation, calcium, etc., and also often they require statins. Anemia is common not only because they can have associated, say, iron deficiency, B12, etc., but also because it has been found that they lose erythropoietin in the urine. And once you are sure that you have supplemented and corrected all those iron, vitamin, then it makes sense to add erythropoietin to these children. Structured follow-up is important, and I'll not go through it in details of it, and in this follow-up make sure that you are doing a thorough examination and looking at the important biochemical parameters. Imaging, one thing to highlight is that if you are having a child with WT1 mutation, then the child needs an ultrasound every 3 months till the age of 7 years, so that you can detect the Wilms tumor earlier on. Make sure that you have identifying all the extrarenal manifestation, and that's why it requires a multidisciplinary team. You need an ophthalmologist, you need a pediatric surgeon, you even need a psychologist, because this WT1 mutation, and if you're going for a gonadal removal sometime, then you need a psychologist. So you really need a multidisciplinary team. Once this child goes into RRT, PD is preferred. Transplant usually works excellent. Recurrence is rare, except for nephrin mutation secondary to FIN major, which we don't encounter that much. So I'll now spend last 2-3 slides on how do we treat CNS in India, because that is an important part of EBM. Is evidence-based medicine is integrating your local practice, vocal for local. I'm sure Modi will, our Prime Minister will like this, vocal for local. So why? Because we are genotypically, maybe we can different. Maybe we have got a variability of medical expertise, variability of health economics, and our ethical concern may not be the same from a Western world. But unfortunately, there are very, very few studies. Only a couple of them I could identify. This one was published by our own group, where we retrospectively identified 65 children with congenital nephrotic syndrome, and it was a very sad story. If you look at the Kaplan-Meier curve, I'm sure it will recall you to the same Kaplan-Meier curve that you saw when we described the 1975 paper or 1976 paper from the Finland. Most of the children died. So half of them were lost to follow-up, and of the half that remained, that half also died. So a very sad story in India on congenital nephrotic syndrome. Recently, AIMS just recently published their cohort of 34 children with congenital nephrotic syndrome, but then they focused primarily on genetic mutation, and they did not publish much on the clinical outcome. But on personal communication, they also said they had a similar sad experience of most of them lost to follow-up or death. So answering how should you treat CNS in India, I am happy and sad and ashamed to say that I do not know how to treat. What happened to our case scenario? Well, our first one, you remember, this is the one who had a homozygous mutation for nephrin. We offered CVL, central venous line, and regular albumin infusion, but they refused. Their follow-up slowly became irregular. The child died at 4 months. Second one, the one with the homozygous conjunctive mutation, we did pass on this message to the family. We did give them a number of calls and said to go for a genetic counseling. But then I don't know what happened, because we have they stopped picking our phone. And third scenario is a better outcome now. This was last month when she came up for a follow-up. Is off albumin infusion, is only one ACE inhibitor, and is doing reasonably well. Fourth one, this is the one with the WT1 mutation who also became albumin dependent on albumin infusion. So they did go ahead, go the full stream. So had a CVL was put on ACE inhibitor, And then during one of the routine ultrasound scan, was found to have a Wilms tumor, went for a left nephrectomy, and as expected, that helped in a sense that the child came out of albumin infusion. But ultimately, by 3 years, went into ESRD. We did a right nephrectomy and CAPT. A transplant was at 4 years, and this was how it was looking last year before the start of the pandemic. So how do I treat CNS in India? As I said, maybe a bit like how blind men sort of identified elephant. Individualized approach, I try to make it. I do emphasize a lot on repeated family communication. Encourage active management for at least initial 6 to 8 weeks. Why? Because in this period, I'm using ACE inhibitor, optimizing treatment, and awaiting for the infective strain and genetic result. Then, as I said before, even if a viral marker is positive, I do advise for genetic tests, and then further management depends on whether we have identified any infective etiology, what was the genetic result, what was the response to ACE inhibitor, and what is the parental decision. And lastly, and very importantly, is the genetic counseling for future pregnancy. So in summary, it is a heterogeneous disorder. Overwhelming majority have genetic etiology, but do not leave any stone unturned till you are sure that you are not missing any infective cause, because that might be the only window of opportunity. Individualized approach, we have repeated it number of times, and genetic counseling, we have repeated it number of times. I'd like to sign off with a happy ending. This is the mother of the first child, the nephrin mutation, homozygous. If you remember, she had lost one fetal in the fetal state, then 3 babies were lost after birth. Then we diagnosed this baby with a homozygous mutation, and then family were found to be heterozygous carrier. Next pregnancy, we did an antenatal test, and unfortunately, again that baby was having the pathogenic variant. So the child mother underwent abortion, medical termination of pregnancy, and averted a catastrophe, and then was blessed with this normal child and a happy mother. Thank you very much.
Thank you, Dr. Rajiv, for taking us through the extensive session of congenital nephrotic syndrome. It was really an interesting topic, and definitely congenital nephrotic syndrome always adds a happy and a sad story. I'm sure you had both the scenarios into your series. Next on our line, we have our next speaker, Dr. Tej Mattoo. Dr. Tej Mattoo is a qualified MD Pediatrics and MRCP from London, UK. He is associated with Wales State University School of Medicine, Pediatric. He's a pediatric nephrologist, and he is a professor of pediatrics and neurology vice chair. His interest is towards nephrotic syndrome, vesicoureteric reflex, hypertension, cystic kidney disease, renal tubular acidosis, and electrolyte abnormalities. I think we have given the right topic to him because his interest is towards nephrotic syndrome. And he has contributed to many chapters in textbooks, and he has got a lot of contributions towards the reputed journals, and he is also editor-in-chief for the Up to Date. Over to Dr. Tej Mattoo to deliver his talk on idiopathic nephrotic syndrome.
Well, thank you, Dr. Congenital, for inviting me to give this talk. I truly wish I was giving this talk in person. Would have been great to catch up with Dr. Glomerular and the rest of your team members. But anyway, this is the best we can do, and I'm delighted to participate in this presentation. The main focus of my talk is going to be the practical issues related to nephrotic syndrome in children. I will not spend too much time on what's already in the textbooks or all over the internet. I must add that I have no conflict of interest for this presentation. So how do we define nephrotic syndrome? The reason, I put some details at the down half of the slide is because when you look at current literature, most of the times it's defined as, okay, when you have more than 1 gram of protein per meter square or more than 50 milligrams per kilogram per day, or urine protein excretion, more than 2, or blah, 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 blah. But the bottom line is that patients with nephrotic syndrome have massive proteinuria. And the dipstick is strongly positive. So depending on, what kind of dipstick you may be using, if it's 3+ maximum you have, it will be 3+ in nephrotic syndrome. If it's 4+, it will be 4+ in nephrotic syndrome. And you can still write papers based on dipsticks. So yeah, you may need to do protein creatine ratios and everything else. But just by dipstick, once you have maximum proteinuria, you got to think of nephrotic syndrome. And besides significant proteinuria, these patients have hypoalbuminemia. And generally, it's believed that it has to be less than 3 grams. But in my experience, I have seen a few patients who did not become nephrotic until they went below 2.5. So personally, I use 2.5 as threshold, but anything less than 3 grams per deciliter would be consistent with nephrotic syndrome. And then the third thing these patients have is pitting edema. So irrespective of the age or the cause or whatever, if you have those 3 things in any patient, your patient has nephrotic syndrome. And in the older literature, when I was a trainee, we also had hypercholesterolemia as part of the definition. And unfortunately, some textbooks still include it as part of the definition, but that's redundant. We don't need that as part of the definition. Now, sometimes we see patients with nephrotic range proteinuria. And what that means is that your patient has same amount of proteinuria as you see in nephrotic syndrome with hypoalbuminemia, but the patient is not edematous. And that can happen sometimes, particularly in older children, teenagers sometimes presenting with nephrotic, significant proteinuria and hypoalbuminemia, and at the same time not having edema. So we should not confuse nephrotic range proteinuria with nephrotic syndrome. For syndrome, you have to have pitting edema. And just as an example for adults, they call it nephrotic range proteinuria if the patient has more than 3 grams of protein in a 24-hour urine collection. Now, 24-hour urine collection in children is not easy, so we can go with different ratios, although I have my problems with protein creatine ratio because I don't think that 2.1 protein creatine ratio is always consistent with nephrotic range proteinuria or nephrotic syndrome. But anyway, these are the definitions, and I would still go with the dipsticks. And if you have maximum on the dipsticks, your patient has nephrotic range proteinuria. How do we classify nephrotic syndrome? There are many ways to classify it, and it's very relevant to know about these classifications because how you investigate these patients and how you manage them depends on these classifications. And anytime you have a new patient with nephrotic syndrome, you kind of go through this checklist of classifications as you make progress in evaluating your patient. And the classification is based on the age of onset. Is it primary or secondary? What is possible renal histology? Could it be genetic versus non-genetic? And then once you initiate immunosuppression, which is always steroids as first-line treatment, is the patient steroid sensitive or resistant? And if the patient is resistant, did it happen with the initial treatment, or did patient respond to initial treatment and then subsequently became resistant to steroids? So the age of onset, you just had a very nice talk by Dr. Sinha about congenital nephrotic syndrome. So this is how we define it. And one of the commonest errors I see people making is confusing age of onset with age at diagnosis. And unfortunately, many times things get published without clearly defining, what the age, which of the two ages were considered for diagnosis. Now, you could have a 4-month-old child coming to you with nephrotic syndrome, and the parents could tell you, well, we noticed some swelling of face when he or she was 2 months old. And you dig more into history and realize that the illness started when the child was about, or the symptoms started when the child was about 2 months old. So that would be congenital nephrotic syndrome, not 4 months when the patient presented, because that would be infantile nephrotic syndrome. Now, that may not make that much difference at that age between congenital and infantile, because the management approach, as we just heard, is kind of very similar. But it does make a significant difference in a patient who is a year old versus less than a year old. So if you have a patient who starts becoming symptomatic at age, say, 10 months, and presents to you 3 months later, it happens even here. It can take a few months for a patient to come to you because, no one thinks of nephrotic syndrome right away. People think of it as allergies, and sometimes they get, treatments by their pediatricians. So if you have a patient who started having symptoms at age 9 months and presents to you at the age of, 13, 14 months, there's a difference. Your patient has infantile nephrotic syndrome, not childhood nephrotic syndrome, just because he presented to you, at the age of older than a year. So it's very important to find out as much as possible when did the child start having symptoms, to be able to classify the patient in right category so that you proceed with appropriate management. Now, idiopathic versus secondary. Why is it important? Because the management of secondary nephrotic syndrome could be very different. And also, when you are doing investigations in patients with nephrotic syndrome, you want to rule out the possible secondary causes because giving steroids might actually cause more problems. So what investigations you do depend on the secondary causes that may cause nephrotic syndrome in your patient population. Now, that patient population may change from place to place. And what I have here is, what we generally do in the US. So one has to think of the secondary causes of nephrotic syndrome and rule them out by a good history. As Dr. Sinha mentioned, history is always extremely important. And history helps you rule out most of the secondary causes of nephrotic syndrome. And then physical exam, and then certain investigations, and I'll come to that. secondary post-infectious GN can present as nephrotic syndrome. But then the patients will have nephrotic presentation, not just straightforward nephrotic syndrome. Vasculites can present with nephrotic syndrome, but then again, the patient will have nephrotic presentation. So not that difficult to rule out most of the secondary causes by good history and some simple lab work. Now, the classification based on histology, yeah, we all are very familiar with that. What's important to bear in mind that these histological types, you get both in idiopathic and secondary types of nephrotic syndrome. So even in secondary nephrotic syndrome, you could have minimal change. But when we say minimal change disease, we are talking about idiopathic nephrotic syndrome, and I see people sometimes mixing up the two. And for idiopathic nephrotic syndrome, the commonest histological types that we see are either minimal change disease or focal segmental glomerulosclerosis. But it's good to know about these different histological types because that's something that helps us prognosticate. And we don't know everything, but given what we know about these different types, it helps us prognosticate and also helps decide on interventions. For example, if it's crescentic GN, then the treatment is going to be very different compared to how you may treat someone with idiopathic nephrotic syndrome. So just remember that both idiopathic and secondary nephrotic syndrome can have very similar histological types, but it's the minimal change that's the most common type in idiopathic nephrotic syndrome. Second commonest being FSGS. And then we have genetic versus non-genetic. And so far, about, it's more than 60 genetic mutations have been described in children with steroid resistant nephrotic syndrome. And about a third of children, steroid resistant nephrotic syndrome, sorry, there is S missing there, about a third of these children have genetic mutation. So if you have, 100 patients with nephrotic syndrome, idiopathic nephrotic syndrome, and you treat them with steroids and 90% respond to steroids, you are left with 10 patients. About a third of them, which is like 3 patients, could have genetic mutation. So that's like 3% of your patients. And the risk of genetic mutation is higher with decreasing age, and we just heard about children less than a year old with congenital and infantile nephrotic syndrome. Most of them have genetic mutation. And then it also increases to about 50% in familial nephrotic syndrome. And we may not see many familial cases in the US, but I would expect that in India and some other countries where certain populations have a higher percentage of consanguineous marriages, you are likely to see more such patients. And nephrin, podosin, and some other genetic mutations are the commonest ones, but as I said, there are 60 different types. So when we talk about the commonest type of nephrotic syndrome in children, it's idiopathic. It's usually in a child who is older than a year. So it's a childhood nephrotic syndrome, not congenital or infantile. Most people don't have any genetic mutation, and it's most likely minimal change. We don't biopsy all these patients. So we can't say that it's minimal change disease. That's another point I wanted to highlight, because people use these terms so loosely, and unfortunately, Many times these get published in literature, and then it gets difficult to interpret, what patient population are we talking about here. So the diagnosis in such a patient is idiopathic childhood nephrotic syndrome. I don't have any problem with people saying most likely minimal change disease, but this is not minimal change disease because the patients don't get biopsied. These patients don't get biopsied up front. We believe that the patient has minimal change. We don't know how many of these patients who get diagnosed with nephrotic syndrome have FSGS and respond to steroids. We don't know that. No one is going to be doing biopsies in all nephrotic patients to answer that question. And to say that the patient has minimal change disease without doing a biopsy is not right. So it's idiopathic. And yeah, if you want to add that it most likely is minimal change, that's fair enough. So how common is it? Well, it's good to know, how many patients you may have in your city or state, because that can be helpful and also gives you some idea where these patients might be going if you are not seeing as many of them. So it averages about 2 new cases per 100,000 children per year. So in Michigan, we have a population of about 10 to 11 million, and we have about 2.5 million kids. So 20 per million means, we should have about 50 patients per year. And if, 15 come to my program, I know, where the others might be going. And in your case, I very often hear that most of them are seen by general pediatricians. And how many end up with peds nephrologists, I don't know. And knowing the incidence in your area might be able to help you answer that question. And most cases are diagnosed when they are younger, less than 6 years and older than a year. And all over the world, it's more common, twice as much common in males as compared to the females. So when you have a new patient with nephrotic syndrome, what kind of investigations do you do in such patients? But the objectives of investigations are to assess the renal function, because first thing you want to make sure is that patient is not in renal failure. You want to make sure that it's straightforward nephrotic syndrome, not nephritic nephrotic syndrome. But nephritic part you can rule out by history and physical exam, because with nephritis, patients will have gross hematuria and would be hypertensive. And if that's not the case with your patient, then you're not dealing with nephritic nephrotic syndrome, and you don't have to do ANCA and many other investigations that you may want to do, anti-GBM and all that stuff. And then also you investigate to make sure that you rule out some important causes for secondary nephrotic syndrome. And urinalysis, important to bear in mind that microscopic hematuria may occur in 20–30% of patients. And that's not nephritis. It's very common in idiopathic nephrotic syndrome to have some degree of microscopic hematuria. Literature, 20%, but I can tell you it's more common than that. Blood chemistry, you want to assess the kidney function, check albumin, and make sure that there's nothing else going on. Complement levels, at many places they may check only C3. But I like doing C4 to look at the classic pathway as well. I don't know, if it's available in, other parts of the world everywhere, but, if you don't want to do C3, C4, you could do CH50 because that gives you the whole complement level. I would be keen on doing C4 in India and other places because, as I said, it tells you about the activation of the classic pathway, and there's a possibility that with certain infections, you may have patients, now this is just my imagination, you may have patients who may have secondary nephrotic syndrome. And if you see C4 is also low, that may give you some ideas, how better to dig more into what may be causing nephrotic syndrome. And in here, we look for ANA, hepatitis, and we check for varicella because that also helps us in the management subsequently if patient gets infected. We do and don't do HIV. For a long time, we did HIV, and some of my colleagues were very keen on doing it. And I know nationally, there are many programs that do it, but I never diagnosed a patient with HIV who presented just with nephrotic syndrome. The patients that I saw were known cases of HIV. We also periodically do TB testing. For a couple of decades, it was a routine thing, just to make sure that we don't aggravate it by giving steroids. But again, I never saw a single patient who we diagnosed with tuberculosis, but that may be relevant in your case, so something to keep in mind. Now, kidney ultrasound, should we be doing it? You don't really need to do it. You can manage patients, without doing a kidney ultrasound, unless, patient is acutely sick and you are suspecting renal vein thrombosis or things like that, then yes, certainly I would do it. But I routinely do kidney ultrasound for a couple of reasons. One, long time ago, I saw a patient with cystic lymphangiectasia of the kidneys who presented like straightforward nephrotic syndrome. And then the ultrasound showed that he had cysts in both kidneys. The patient is published in Peds Nephrology. And it's that patient that had unilateral nephrectomy and gave me the idea to try it in congenital nephrotic syndrome. That's how unilateral nephrectomy evolved in congenital nephrotic syndrome. So with that patient in the back of my mind, and then also what happened on another occasion was that I was treating a child with nephrotic syndrome, and that happened here, and didn't have a kidney ultrasound exam. And then about 2-3 years later, when the patient was doing very well, the dad told me that he said, "Hey, you never told us that John has only one kidney." And I said, "How do you know that?" He said, "Well, John had stomach pain, and we took him to the emergency room, and they did his ultrasound, and they told us that he has only one kidney." And that was very embarrassing to me, because here I'm his nephrologist, having treated him for 2-3 years, and not knowing that he had only a single kidney. Now, that's not good enough reason for you to be doing ultrasounds, but I do it because it's a simple investigation, readily available. But if your patient has to travel 50 miles to get an ultrasound done, and there's no other reason to do it other than just straightforward nephrotic syndrome, then I wouldn't do it. In blood chemistry, one of the interesting things that I still see in textbooks is this issue of serohyponatremia, because it's very common to see low serum sodium levels in these patients when they present first time. And it's been called pseudohyponatremia, and it has been attributed to how serum sodium is measured, and how the presence of lipids affects that measurement. And that's what so many people still believe. But that's not true, because the methodology for electrolyte measurement changed about 20 years ago. And when I realized that the methods used were actually measuring true sodium, not sodium level affected by lipids, I had one of my fellows, Dr. Kapoor, do a study, and turned out that the measurement is accurate, and these patients do have hyponatremia, And why they are hyponatremic, we don't know. We assume that this is the addition of non-sodium and non-potassium osmoles in response to plasma volume contraction caused by hypoalbuminemia. And I haven't seen any other publication on that. And this is a very interesting area to look into. And if you have enough patients, you may want to dig more into it. But this has nothing to do with the measurement. Now, should these patients be having genetic testing? The commonest argument in support of some of my best friends in Europe and United States, and even in UpToDate, of which I'm the editor, the author for this chapter, Patrick Neode, who I'm sure most of you know, uses the same argument. And many of my friends in the US, the same argument that, well, you do genetic testing and then you don't have to use steroids. Here are a few things that you must remember. That less than 5% of children with idiopathic childhood nephrotic syndrome have a genetic basis for nephrotic syndrome. And I can assure you that even some of them, you are likely to try immunosuppression, because that's what I do here. And that way you are left with maybe 1 or 2% patients. And I want to share with you an example I came across maybe about 15 years ago when I was doing a study funded by National Institutes of Health. I was looking at the possibility of plasmapheresis helping remission in steroid resistant nephrotic syndrome. And during that study, I had an African-American family. The dad was a known case of FSGS, and he was on dialysis. And his 2 sons that I was taking care of both had nephrotic syndrome that did not respond to steroids. They both had biopsies and had FSGS. And interestingly, one of them went into complete remission with tacrolimus and steroids, and the other one was on dialysis within 18 months. Same family. And I never forgot that family. I don't have their genetic results because this is about 15, 17 years ago. We didn't have any routine genetic testing that time. And then the other thing to remember is that once you do genetic testing, there is no unique treatment you can offer based on genetic testing. You still end up struggling with the same immunosuppression. And if they respond, that's excellent. If they don't, they end up on end stage. But there's one exception, which is coenzyme Q10 deficiency. So if I had to do genetic testing in my patients with steroid-resistant nephrotic syndrome, that's the one I would do. Although even in those patients, you can have some other clinical clues. It's an autosomal recessive mitochondrial disorder, and patients have heterogeneous neurological, renal, and muscular symptoms. So these patients do come with symptoms, although those symptoms may not be that prominent at the time when the child presents to you with nephrotic syndrome. And they have a decreased blood CoQ10 level. And there was a paper published recently from the US from a group of our nephrology friends in the country. And they reported that the white cell level was actually normal in some of the patients. And multiple genetic mutations have been reported in these patients. And it's a treatable condition. That's the exciting part of the genetic test. So like you heard about congenital nephrotic syndrome because of syphilis, that you can treat with penicillin and the patient is cured, this is one more condition to keep in mind. And this is where genetic testing is worth all its money and effort. Now, as per the literature, these are the conditions where you should be thinking of genetic testing. And I put may in there because if you don't have access to genetic testing, don't worry, you can still do a great job on 98, 90% of your patients. So if it's steroid resistant, nephrotic syndrome, or there's family history, and I just give you an example of the family I had the privilege of knowing. Consanguineous parents, again, I would put question marks against consanguinity as well, because if the genetic test was like CBC, then I would do it on every patient. But if it's going to be a economic drain on your patient or your institution or the healthcare system, then you don't need to rush into it. But you may consider. So how do we treat these patients? Well, it starts with treatment of edema. We want to induce the remission. We want to prevent complications. And then in the past, we talked about treatment of hyperlipidemia, but there is no evidence today that the treatment of hyperlipidemia is necessary, because it gets better, it resolves as the nephrotic syndrome responds to the treatment. And for edema, the biggest debate is diuretic with albumin or diuretics only. And in the US, most cases get diuretics with albumin, where I know in India and so many other countries, they get diuretics only. And it seems that you guys do as good a job with just diuretics as we do with diuretics and albumin. Fluid restriction, I don't believe in that, because if the patient is thirsty, he or she will find ways to drink more fluids. It's a dietary sodium restriction that works the best, because these patients have a significant increase in total body sodium, although the serum sodium is lower. And restricting their sodium helps in the management of edema quite a bit. And it also has quite a bit of educational value. The parents get to learn about how much sodium the patient. I start with 50% decrease in dietary sodium, and that generally is enough to help treat them and also prevent. When they have relapses, they don't become edematous that quickly because patient is not on high sodium diet. So about the diuretics and diuretics only versus diuretics with albumin, we did a study. Dr. Kapoor was my fellow, and we looked at FINA and figured out that those with FINA of 0.2% could be safely treated with diuretics only. Now, this all may be irrelevant for you because, as I said, most of you just use diuretics anyways. But again, there's a need for repeating the study in a bigger patient cohort, because lots of patients, particularly in the US, still get albumin. And it's not just the cost factor that bothers me, but I'm not sure about the long-term implications of this massive albumin administration in such patients. Could this be contributing to their renal injury? I don't know the answer, but something worth looking into. For the treatment, I don't need to go through this. It's all, in the textbooks, and generally, most protocols give daily steroids for 4 weeks, and we use either 2 milligrams per kilogram or 60 per meter square. And then after 4 weeks, there are different protocols. Overall, most patients get 3 to 4 months of steroids for initial episode. And most patients respond within 4 weeks. Now, in the past, we actually, a long time ago, we didn't call steroid resistant until we had tried 8 weeks of steroids, because there are a few patients who may respond to treatment in the second month. But that's very few patients. So that's a reason this 4 weeks is the kind of standard definition now. But if you have a patient whose urine dipstick has gone down from 4+ to 2+ on day 28, the patient is responding. So, you just continue treatment, same dose, for more than 4 weeks. The patient will go into complete remission. So you may have to change the protocol a little bit. Just remember that a few patients may take more than 4 weeks, definitely not more than 8 weeks, to respond to initial steroid treatment. And what happens after treatment? About a third of them may have infrequent relapses. Another third may have frequent relapses. And approximately a third may not relapse. And a few patients become steroid resistant. So after initial remission, we use steroids for 3 scenarios. One is when a patient relapses, we treat them with steroids. And the dose is the same as for initial treatment. The major difference being that we don't give them steroids for 3 to 4 months. For a relapse, they get a shorter duration of steroid, generally around 8 to 10 weeks. That's the most significant difference from initial treatment. Then we also use steroids when we have a patient who is either resistant or is having frequent relapses, and we want to use any other immunosuppressant. We use steroids along with, because it helps induce remission. Starting dose is the same, but then the weaning duration can be variable depending on clinical progress. It can be a few weeks and sometimes longer. And then we also use steroids for prevention of a relapse, and it's also called maintenance steroids. And this is every other day steroids, 0.5 milligram to 1 milligram per kilogram body weight. This is a concept that Dr. Alzuki and Dr. Srivastava from AIMS, they published it in late 80s, early 90s. And I have my patients on maintenance anywhere from 6 months to 2 years, depends on clinical course. And then also, many years ago, I learned that for those patients who are on alternate day steroids, if you give them daily steroids with the onset of URI for 5 days, you could significantly lower the risk of a relapse. Now, what this essentially means is that giving 2 extra doses, because anyone who is on every other day steroids, 5 days means just 2 more doses, and you see a significant decrease in the relapse of nephrotic syndrome. But the key is to start this regimen at the onset of the URI, not when you are halfway through the URI, then it's too late. And it does help, and the studies have been repeated. Dr. Gulati from India and then a couple of studies from England have shown that this is helpful, and something to keep in mind if your patient is on every other day maintenance steroids. Now, what about non-steroidal immunosuppression? Well, this is Cochrane's review. Now, this is for steroid-sensitive, frequent relapsing, steroid-dependent patients. A lot of talk about rituximab, which is a great new tool that we have. But keep in mind that the effect is temporary, and many children require additional courses of rituximab. And we don't know the long-term side effects. So, yeah, it's wonderful to have this another medication, but use it carefully. And then the choice amongst other immunosuppressants. Well, you just need to know how best to use any of them, because there's no evidence, actually, convincing evidence that one is truly superior to another. And this is Cochrane review, from last year. And I believe in that because of my own clinical experience. You just need to know how best to use the medication rather than just blindly following the literature because someone published that tacrolimus is better than levamisole or, the rituximab is better than everything else. Now, for steroid-resistant cases, again, same medications, but then there are some people who may use IV pulse glucocorticoids. You heard about Mendoza's protocol, but then also in France, they still tend to use some high-dose steroids. Now, the point I want to highlight is we don't use cyclophosphamide in steroid-resistant patients. We stopped using that a long time ago in the United States and in Europe. But if that's the only medication that's available, in certain parts of the world, or is affordable in those parts of the world, then yeah, you could still try it. And this is a study that was published in a Saudi journal when I was there. And the reason I published it in a Saudi journal is because I came across loads of patients with nephrotic syndrome when I landed there, and most of them were steroid toxic. And when I started using Cytoxan, because that was the only medication, calcineurin, cyclosporin had just appeared in the market. I started using Cytoxan, and some pediatricians, they were upset because they thought, this is going to make boys impotent, and this may be against the religion. So they, it started getting politicized. But here I was seeing, how much better these patients were doing. So I went around giving talks, showing them slides of those patients before and after. And then I also published it in the local journal, showing, how well those patients were doing. And I just want you to look at the steroid resistant part of this slide. That's the lower half of the slide. So, there were patients with steroid resistance who responded to steroids with Cytoxan, about half of them. Something to keep in mind. And then in the US, I had another fellow from Egypt, Ahmed Al-Rafai, and he was interested in looking at collapsing versus non-collapsing FSGS. But look at the non-collapsing FSGS, on this slide. None of the collapsing FSGS patients responded to any immunosuppression. But 13 of 28 patients with non-collapsing FSGS in the US responded to immunosuppression that included prednisone, cyclosporin, and MMF. Tacrolimus was not even used at that time in these patients. So even for steroid-resistant patients, we saw a 50% recovery with these medications and complete remission at close to 2 years follow-up. Now, which of these patients should have a kidney biopsy? Well, at initial presentation, as you heard Dr. Sinha said earlier, it's not an absolute necessity, but you may want to consider doing it in a child who is less than a year old, because this is what the current literature tells you. And as you heard in the earlier talk, that the guidelines and other literature out there does not mean that you have to do it. You may change the approach based on the clinical scenario of your patient and the resources available to you. Definitely nephrotic presentation, that patient has to have a biopsy because your management could be very different. Syndromic nephrotic syndrome, it could be helpful. Familial could be helpful. Age less than 12 years, recommended. I don't do it. I would give them a trial of steroids and see if the patient responds, then take it from there. If the patient doesn't respond, then I would biopsy. Then patients who have responded to steroids, if patient, a patient who have received steroids, so the patient hasn't responded, you consider doing a kidney biopsy. And then also for those who have late delayed resistance to steroids. And also, as per the current literature, before using nephrotoxic medications, calcineurins, particularly, most of the institutions still do protocol biopsies. But let me show you something here. There was a time when we did kidney biopsies before using Cytoxan. This was standard of care a long time ago. But then, we learned that it's not necessary. No one does kidney biopsy before using cyclophosphamide anymore. And I'm talking about steroid-sensitive patients. And then very recently, my other fellow, did a study looking at the usefulness of protocol renal biopsies in nephrotic patients who received calcineurins. And as was my clinical impression too, turns out that protocol biopsies are not necessary. You don't need to do a biopsy before starting calcineurin, or do it, 2-3 years into the treatment that many people, including some of my colleagues here in Detroit, do. You may do it selectively, and we don't have time to go through the details, but the paper is going to appear in Clinical Nephrology. It should be appearing anytime now. And if you are doing biopsies in patients who are receiving calcineurins for nephrotic syndrome, you may want to read this paper and see if you can avoid doing biopsies in such patients. The long-term prognosis in children with idiopathic nephrotic syndrome is excellent. And when parents ask me what's the long-term prognosis is going to be, I don't base it if the patient was steroid resistant, had a kidney biopsy, blah, 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 blah. I just base it on steroid sensitivity. That's a much better long-term prognostic indicator than anything else, including biopsies, genetics, everything. If your patient has responded to steroids, is steroid sensitive, the prognosis remains excellent. Parent education is extremely important. It's very helpful to teach parents about the urine dipstick examination, because then they can be managed from home. And all our patients here do get trained, and I started doing that in Saudi, and I can tell you that if Bedouins there could do it, there's no reason why no one else on earth can do it. You have to educate these patients on decreasing dietary sodium. It's not only helpful for immediate management, but it helps in those who have recurrent episodes. And then also it's a good thing they get used to going forward. They get used to not having too much dietary sodium. Prevention of infection, and that's more relevant to how it works in places like India and other developing countries. And then this initiation of daily prednisone, the parents have to be educated on that if you want to do it, because it needs to be started at the onset of URI. And it's something that parents have to be aware of, because then only you can do it. So in summary, everything that responds to steroids is not minimal change. We assume it's minimal change, but we don't know. Most patients with idiopathic childhood nephrotic syndrome can be managed successfully with proper use of steroids and some readily available medications. And once again, I would emphasize that we just need to know how best to use the medications available at each place. Kidney biopsies, there's a lot of fascination about kidney biopsies, but what I have learned over the years is that we don't need to do as many kidney biopsies. We should be selective about it. And before you do a biopsy, ask yourself the question, is this going to change your management? If you have a patient who has frequent relapses or steroid resistant, and you decided you are going to start patient on calcineurin, is biopsy going to change that? If the answer is yes, then do it. If not, then don't do it. And then genetic testing, I think it's a great new tool that we have. It's taught us so many things, and we need to keep learning based on new genetic studies. But I can tell you that it's not an absolute necessity in the management of steroid-resistant nephrotic syndrome. I can assure you that you can provide top-notch quality care to your patients, even with steroid-resistant nephrotic syndrome, if you don't have access to genetic testing. I strongly believe that, that there's a need to do a lot of research on nephrotic syndrome to answer so many simple questions. I'm not talking about high-tech questions, so many simple questions. We have made a lot of progress on this subject since I became a nephrologist many decades ago. But we still have so many simple questions that need to be answered. And the greatest resource that you have, which we don't have in the United States or in Europe, is the number of patients. And I would strongly encourage you to use that resource and try to answer many of these simple questions. And feel free to contact me if I can be of any help, if you want to do that. Thank you very much. I appreciate your attention. Sorry, I may have gone over time, but I can't help talking again.
Thank you so much, sir. It's always actually nice to listen to great teachers talk, as they are the people who can really drill the subject into us. I'm sure Dr. Mattoo did a great job. Thank you so much, sir, for taking us through the journey of idiopathic nephrotic syndrome. Next, we'll have the polling session. I request us faculties to kindly hold on for 8 to 10 minutes till the polling session was over. Then we'll take up the question and the answer session. So we'll move on to the polling session. So the instructions for the polling session will be like, I request all the participants to enter their proper email IDs and contact numbers for future communication. And totally we have 7 polling sessions. Already we are done with 2 and we are left with 5 more sessions. And each polling session will have 10 questions, and it's mandatory to answer all the questions to proceed with the submission process. And the total duration of the polling session is for 8 minutes, and we have 3 star questions out of the 10 questions, and the star questions are taken into consideration in case of tie. And the cumulative score of all 7 polling sessions will be taken for the final scoring. And only trainees are allowed to participate in the polling session. And I request all the participants to log in on time using a bigger screen. And so now we'll take up the polling session.
I just finished giving a talk.
Can we have the questions for the polling session? We have started the questions for the polling session. We are done with the polling session. Tej sir, Dr. Rajiv, you're there. Can we take up the question and answer section?
Yes.
We'll take up the questions. The first question is, had a child with congenital nephrotic syndrome secondary to congenital toxoplasmosis. IgM was strongly positive. Am I right in starting anti-toxoplasmosis drug? Dr. Raju, would you like to take this question?
Yeah, I saw that question. I think it's from Manoj.
Yeah,
And
it's from
so first of all, you have to be very sure whether it is a congenital toxoplasmosis or not. As far as I know that there is not much harm in starting the drug, but as we discussed before, that many a time these are red herring. I'd be interested to know whether this child had any other features of congenital toxoplasmosis, starting from antenatal right up to like any features in the brain, eye, etc. And then if you're very strong evidence, then you should start, because there are reports where congenital nephrotic syndrome has been treated for toxoplasmosis and it has responded.
Okay.
But also remember
Thank you.
the red herring about it. Do the genetic also.
And the next question is there any role of renal biopsy in a child with proven genetic mutation causing nephrotic syndrome? Dr. Rajiv or Dr. Tej, can you take this question? It's pertinent to congenital.
I think both of us conveyed the same message that biopsy may not always be helpful, and you got to ask the question: is it going to change your management? And if it does, then do it. But I wouldn't hold back the possible interventions that may be available at your place just because you cannot do the biopsy.
Okay. Okay.
And one thing I would like to add, Dr. Clevin, is that doing a biopsy in 1 month, 2 month is not very easy. I mean, when I came back to India, I used to hear people saying that, sir, I have done a biopsy in a month-old child and feeling very proud of it. Maybe he has done it and he has get away with it. But then if he start, but I'm sure that if he start doing it routinely, then you will get in problem, and you don't need to do it. So in a small baby, it is difficult to do a renal biopsy. And why would you subject the child to a renal biopsy if it's not going to change your management, apart from saying that, yes, I have done a biopsy in a month-old baby.
Okay. And the next question is to Dr. Tej. COQ mutation, will the supplement of COQ help in treatment?
Yes. Yeah, it takes months to, maybe more than a year, but then yes, yeah.
It requires continuous supplementation of COQ?
Yeah, this is the definitive treatment. This is the definitive treatment, and the treatment is available. But again, I don't want anyone listening to my talk to say, okay, this is what I got to look for. We're talking about less than 1%. So almost all patients that you will see don't have, this enzyme deficiency and won't need this treatment. But it's good to know that there is this condition where treatment is available. Yeah.
Okay. And the next question is, do we define a child with steroid resistant nephrotic syndrome or severe steroid dependence if a child goes into remission, resolved edema, dipstick negative on 2 milligram per kg steroids, but relapses on the same dose in a period of subsequent 10 to 14 days, that is before the switch from 1.5 per kg alternate days? Do such children eventually or at higher risk of SRNS? Shall we prefer biopsy or go for an early genetic or as possible initial resistance in such cases?
Well, I hope I understood.
It is the typical age of presentation.
I hope I understood the question right. So the question is that if you have a patient who goes into remission with standard treatment, but then relapses when you are weaning steroids, right?
Yeah, like even with soon after switching over from 2 milligram to 1.5, the child relapses.
To me, that could be an early indication of steroid-dependent course for this patient. Now, what happens, year 2 or 3 down the road, is something that one could study. Again, that's where the patient population comes in. If you have enough patients, But to me, someone who relapses when you are weaning steroids after the initial 4 weeks treatment would be indicative of a steroid-dependent course, unless this patient had some infection, something, because that increased the risk of relapse anyway. I would, as a clinician, I would, in the back of my mind, keep this possibility that this patient may have a steroid-dependent course. And what I would do is, I would treat him as per the protocol. I actually, after 4 weeks, I wean them off, over next couple of months or so. I would continue with that, but then I would watch this patient a little bit more carefully, trying to see if my initial assumption that this patient will relapse soon comes true. And if that's real, then this patient should relapse within the next, few weeks. If that doesn't happen, then it was, whatever it was. It doesn't have to be taken seriously. And definitely, I wouldn't make a decision on kidney biopsy based on someone relapsing when I'm weaning steroids. No.
Is the genetic testing indicated in these children? Early genetic testing. That's what the second part of the question is.
No. See, there's a difference between having relapses and remaining steroid sensitive versus someone becoming steroid resistant. That's why for all my trainees and patients, parents, I tell them that as long as your patient or your child is steroid sensitive, doesn't matter how many relapses, this and that, the prognosis is excellent. You may end up using more immunosuppression other than steroids or maintenance steroids or whatever. But as long as patient is steroid sensitive, so someone relapsing when you are weaning steroids and then going into remission when you continue with the steroids, there's absolutely no indication for kidney biopsy.
Okay. The next question is that the most common nephrotic syndrome in around 1 to 3 years old or more than 1 year old? Which is correct. I think the question is not complete. Probably they're asking about the minimal change nephropathy. I'm not sure. The question isn't complete.
Well, so the next question. Most children are between the age of 1 and 7, 8 years, most of them. But then we do see sometimes teenagers. And since that's a little bit atypical, that's why some people would recommend doing biopsies on those patients. But I still try steroids before I think of a biopsy. But most children are between the age of 1 and 7 to 8 years.
Okay. The next is, it's a comment for Dr. Tej Mattoo. Excellent presentation. Totally agree with the unnecessary need to do so many protocol biopsies while on CNIs and before starting CNIs. That's a comment from Dr. Manoj. And the next question is, if the child is on alternate day prednisolone, if the child is on alternate day prednisolone at 0.5 milligram per kg, and if the child develops infections, what should be the dose of steroid? Please clarify, sir.
Same dose. Same dose, just give it daily.
For 5 to 7 days and then switch over to the previous dose. Am I right, sir?
No, not. I mean, the study was 5 days. So what that meant was 2 extra days of same dose steroid. But as I mentioned, it has to be given at the onset of URI. Because as we know, the relapse is related to cytokine expression. And once you have had URI for a few days, the cytokines are already out there, and whatever they have to do is already done. And at that time, giving this small dose daily is not going to help much. You have to give it within a day or two. That's where where parent education becomes so important. And I just tell my parents, they just actually even started and then let my nurse know that, oh, we did this because Johnny started coughing or sneezing. And it's there's no risk in it. It's a small dose, and every other day to daily, just for 5 days, helps quite a bit.
Yeah. The next question is, for how long CNI is continued in steroid-resistant nephrotic syndrome case, achieving complete remission after 6 months of CNI initiation?
Patient is in remission.
Patients, it's basically a steroid-resistant, was on calcineurin inhibitors for 6 months and attained remission after 6 months. In that case, how long do we continue CNIs?
Well, I love that question because that's the kind of situation which puts you in a very tough situation. What you should be doing going forward. On one hand, you are tempted to continue with the medication because your patient is in remission. On the other hand, there is a real risk of actually inducing calcineurin-induced nephrotoxicity. I generally don't make that call for about 2 years. I want to see patient in remission for 2 years. And then at 2 years, there are many ways to deal with it. One is to see if you can decrease the dose. I don't know, it depends what dose your patient is on, and see if you can lower the dose, at least to lower the risk of CNI toxicity. Second is take a chance and, if parents and patient buys into it, wean the patient off calcineurin and see what happens with the possibility, and I have been there, that the patient may relapse. And then the third possibility, and that's one of my, one of the indications in this paper that I mentioned is about to get published. You may think of doing a kidney biopsy, and if there's no evidence of CNI toxicity, then say, okay, patient is in remission, let me just continue it for another year or so and see what happens. I know it's a long answer, but it's a very good question because it happens. And what we need to make sure, and I have seen a couple of patients like that, where excitement to induce and maintain remission, we don't cause long-term CKD because of the medication that we have used. It's a very tough balance to strike. And that's one of the things why we need more studies.
Okay. Probably we'll continue for 2 years and then wait how the child is responding, look for remission.
It's patient. I mean, I personally, I continued for 2 years. And then at 2 years, I start wondering, okay, what should I be doing next? With the possibility, I may just continue the medication. I may continue on the same dose. If there's a scope, if the patient has been on a relatively higher dose, I may reduce the dose and see what happens. And that's the time I use protein creatinine ratio. And if I see protein is showing up, I just go back to the dose patient was on. Or I may, depending again on clinical situation, I may do a kidney biopsy, and if there's no evidence of CNI toxicity, it again is patient dependent. I may say, okay, then let's just continue the same dose.
Okay. And the next question is, what is the role of immune system in the pathogenesis of idiopathic nephrotic syndrome?
Well, we need a separate talk on that.
Okay.
It is immune mediated. There's no doubt about that. And
that's true. It's quite a longer thing to be answered.
Well, one example I can give is, although we are not so sure if FSGS is same as minimal change, although we don't know how many patients with FSGS behave like minimal change by responding to steroids. But we know very well in those patients that they get a recurrence in transplanted kidneys in a matter of hours. So there is very active immune system involved here, and possibly something in the blood that goes in the kidney and causes proteinuria within hours of kidney transplantation. And that's the reason why people are interested in issues like, interventions like plasmapheresis. And as I said, I did a study which was funded by NIH many years ago. And I could recruit only about 10 patients, which was not enough to come up with anything meaningful, but there is still interest in that subject. So yeah, definitely. And if you are interested in immunology, there's a lot of immunology involved here, but that's a separate talk.
Okay, thank you so much, sir. And the next question is to Dr. Rajiv. It's a request. Can you please summarize the treatment of a girl with WT1 mutation in congenital nephrotic syndrome? Dr. Rajiv?
So, girl with WT1 mutation and having a congenital nephrotic syndrome, we should, the only difference is a couple of things. One is that we should have a karyotype done. If the karyotype is showing a 46XY, so it is a phenotypic female, but a karyotype of 46XY. That means there might be a Frazier syndrome-like sort of thing, or a gonadoblastoma. So it may not even be a Frazier syndrome, but these children have a higher risk of gonadoblastoma. And their gonads have to be removed. Apart from that, they have a higher risk of Wilms tumor, so they should undergo ultrasound scan monitoring as frequently. And if you're having a Wilms tumor, then treat as per the guidelines. And if they go into end-stage renal failure, girl or boy, if they go to end-stage renal failure, then you remove the kidney. So from a WT1 perspective, these are the 2 and 3 important changes, like doing a karyotype so that you are not missing a potential future gonadoblastoma, and following up the ultrasound kidney with the ultrasound. Apart from that, other management is the same, and usually from we have got about 5 or 6 children with the WT1 mutation, and from our experience, they seem to be slightly milder than their nephrotic syndrome than pure nephrin homozygous mutation. And sometimes we can get away with not going for the full aggressive. But obviously, I would like to hear Dr. Mattoo's comment also on this, because with a greater availability of genetics and they must be having a better experience on this.
No, you said everything right, but what I got excited about is you have 4 or 5 patients with WT1 mutation, so you could actually teach the rest of the world about it. No, I agree with everything that you said. Yes, yeah.
Okay.
In India, number of patients is not a problem. And again, in this forum also, I'd like to request, and I'm sure Dr. Kalavani will also agree that the number is not a problem, and we would be happy to go into collaborative research, etc. But this problem is mainly the funding, because we have got other priorities, and getting funding for nephrology is not that easy.
Well, I know how helpful funding is, but I'm sorry to put it that way. that should not hold you guys back. I mean, you are doing amazing work. The patients that you mentioned, the two of them survived. It's so different from what it used to be like in India, and as you said, even in Finland in '75. For you to have your patients do this well, no, I'm not kidding. I mean, I'm very, very impressed because that's cutting edge nephrology. So research has to be part of it. And, I mean, WT1 mutation 4-5, I mean, you could write a book on just WT1 mutation from there. Just the clinical outcomes in those patients. You could write, tons of papers down the road. So, no, I mean, there's a lot happening in India. We have had some senior pioneers there, and I had the privilege of knowing many of them, but it's so good to see younger generation actually, taking lead and doing amazing stuff. And I just hope that you guys take full advantage of the patient population you have.
Definitely, thanks.
Thank you, sir. Next question is to Dr. Mattoo. Are we overdiagnosing or incorrectly diagnosing relapse of nephrotic syndrome by using the definition proteinuria of 3+ or more for 3 days to escalate steroid therapy? Edema is one of the 3 criteria for diagnosis of nephrotic syndrome. There is an assumption that they all will eventually develop edema. I have observed in my practice that it's not true in many who improve without requiring the standard steroid regimen for treatment of relapse. I would value your comments, sir.
No, that again is a very good question because you see, once you have initial presentation, the parents know nothing about nephrotic syndrome. And as I said, even here in the US, for childhood nephrotic syndrome or even congenital nephrotic syndrome, we sometimes have 2-3 months before patient sees a nephrologist because, parents first ignore it, a little bit of swelling, okay, it's nothing, then grandmother may have some treatment, and then the pediatrician thinks this may be some kind of allergy and tries some anti-allergic medications, and by the time the child is more symptomatic, it could take a few months. So for first admission or first presentation to a nephrologist, the parents are not well educated on the subject. And for diagnosis that time, your patient has to have nephrotic syndrome unless it's one of those patients who has nephrotic range proteinuria, which I said happens more often in older children, not in younger children. For a relapse, it's different because now the parents are educated, and if they are doing Diuretics at home, and they know that it's been negative, and then they're seeing that child has a URI, and it became 1 positive, and then 2 positive, and third day it's 3 positive. The child is not edematous yet. Yeah, that's a relapse. So that time you don't have to have edema. The parents may diagnose it even before the child develops edema.
That's true. Probably like parents' education helps more to pick up relapses early.
Well, it's not perhaps. They actually help you manage the patient, and in India too, because some of these patients may have to travel long distances. If you teach patients how to do it, I mean, as I said, when I was in Saudi, I started their first children's kidney program, and these patients were coming from not all over Saudi, but also from other Gulf countries. And what was so helpful was these parents doing Diuretics at home, because then we could do the rest on phone. Sorry, I don't know if we got disconnected because my video disappeared for a few seconds. Did you hear my answer?
Yes,
or do you want
No, I'm connected.
Did you hear my answer?
Yeah, I did
Okay.
hear your answer, sir.
Okay. Okay.
The next question is the kid relapsed on this is a continuity of the question previously you had answered. The kid relapsed on 2 milligram per kg itself before switch over to alternate days. The
Yeah.
question which was answered before, whether the child requires renal biopsy when the child is on
No.
full dose steroids.
No renal biopsy, but watch this child for possible steroid dependent course.
Yeah. The next question is, can vaccination trigger relapse on nephrotic syndrome?
Not to my knowledge, no. But you don't vaccinate, you don't give any live vaccine until they have been in remission for some time. Yes, yeah.
Next question is, how do we account for stress dose steroids if someone has received for longer than 10 to 14 days when accounting for duration of daily steroids for defining steroid resistance, as it is much lower dose than the induction dose?
Well, I'm not sure I understand the question. We are talking about maintenance for patients in remission, not for induction, not for induction of remission. For induction, not just in nephrotic syndrome. In so many other disease entities, the dose for induction can be different from maintenance. So, yeah.
Next question is, are all forms of genetic nephrotic syndrome non-responsive to steroids? Do some genetic forms respond to steroids?
I say yes. I say
Dr.
some
Rajiv, would you like? Yeah, I'm sorry.
I wouldn't say so for congenital infantile nephrotic syndrome. I'm talking about childhood nephrotic syndrome. In fact, the argument that don't even try steroids in some of these patients up front, I would still try steroids, see if that helps. If not, then I know that, there's not much I can do. But the argument for younger children, less than a year old is very different. And I'll let Rajiv answer that question. Yeah.
Dr. Rajiv, would you please add on?
I completely agree. For less than one steroid or other CNI, not much of use, most probably. Now, whether genetic mutation, suppose in a older child also, if you're having a genetic mutation proven, and whether the child should be subjected to steroid or CNI, this is a question that I'm sure we all know is being explored quite actively at the moment. And we have to remember that our knowledge, all of this of genetic has been coming in the last decade only with this upcoming of the NGS. So completely shutting the door may not be the right approach. And at the moment, I know that there are studies going on. There is a study by Dr. Tullas from UK, who is recruiting again information across the world, like whether genetic mutation has with children with genetic mutation has responded, and there are case reports also of a certain genetic mutation responding to some type of immunosuppression. So, but the important thing for the audience will be keeping India in perspective is that if you are going to try some immunosuppression in a child who is known to have a genetic mutation, first of all, this should be only done by a pediatric nephrologist and after proper counseling the parents.
Yeah, I have never used any immunosuppression in a child with congenital or infantile nephrotic syndrome. But I am aware of very few instances where people reported that patient went into remission with steroids. And I don't know enough details to feel convinced that immunosuppression works in the first year of life. And as I said, I have never ever used it.
Okay. There are a few papers which quotes that PLCE2 gene mutation responds to steroids.
Yeah, yeah, there's not enough reported in those publications to convince me. So as I said, categorically, I have never ever used immunosuppression in a child with congenital or infantile nephrotic syndrome.
Okay. The next question is, your opinion, is there a possibility of reducing duration of daily steroids in 4+4 or 6+6 weeks regime in treatment of first episode of idiopathic nephrotic syndrome? Probably tapering down to 2 weeks.
No, yeah, people have, I mean, there's a long answer to this question, but right from ISKDC to German studies to more recent studies, including some studies from Dr. Baga and his team at the Ames. People have studied anything from 2 weeks to 6 months of steroids. And the conclusion is that 3 to 4 months is enough and the standard of care. And if you look at Cochrane's also, and even my personal experience, and most people would agree that that's what we need to continue with. Okay. There are lots of studies that tried shorter duration versus longer duration, but no, the outcomes are not significantly different.
Okay. Probably we are done with the questions. Thank you so much, sir. It was an excellent discussion on congenital nephrotic syndrome and idiopathic nephrotic syndrome. We had a great discussion. I'm sorry for taking a long time on your weekend. Thank you so much.
No, it's fine. It's fine with me. It's morning time. It's going to be noon time, so I'm okay. It's you guys, staying late on Sunday night. But anyway, it's great to see you. I appreciate you putting this program together, and truly enjoyed my participation. And Rajiv, it's great to see you too. And I'm sure there are many other friends who were perhaps attending. And I'm going to miss you guys because I haven't been able to see you. But anyway,
yeah,
hi to everyone. Hi to everyone. Stay safe, and I hope things in India with COVID get better very quickly. And hopefully we'll catch up with you sometime soon. Have a good night for you guys.
We have a live session soon, sir.
Thank you, Dr. Mattoo. And Dr. Kalaivani, thank you very, very much.
Thank you so much, Dr. Raju. Thank you so much. It was an excellent time with you all. Thank you so much, sir.
Thank you.
Bye-bye. Good night.